Good day to all of you. The topic for the lecture will be about physical abuse in children. Now, I would like to request you to have an open mind and an open heart because I know this is a very sensitive topic, especially for some of you who might have experienced some form of physical abuse before, or you have also witnessed some form of domestic violence. Now, let me share with you numbers in terms of abuse cases, and this was taken from the report of UNICEF. And they said that 1 out of 5 children suffer from sexual abuse at home, in the school, and in the community. And 2 out of 5 children commit form of physical violence with their peers. Now, 3 out of 5 children admit experiencing some form of psychological violence, and 4 out of 10 children grow up seeing some form of physical violence at home. Remember, I mentioned in my last lecture that children who have been exposed to domestic violence are also victims of violence. 5 out of 10 children suffer from cyberviolence, and 6 out of 10 children are physically and psychologically abused, and 7 out of 10 children do not avail of local child protection systems in their community. So there has been an intense information campaign to children, to adolescents, and even to parents and other members of the community that there is always a place or an area, or they can report the cases of suspected abuse. 8 out of 10 children who are LGBT children are physically and psychologically abused, and 9 out of 10 children think that parents act in the best interest of the children. So this is something that we really have to reflect on, that children would really trust their elders, no? Especially their parents who's taking care of them. So it is really very ironical that some of the abusers are their parents themselves. 10% of children are physically neglected by their parents or guardians. Now, the slides of my lecture are taken from the Child Protection Unit Network, and some are actual cases that we have handled at the WCPU. So I would like to request you not to take pictures of cases that we have seen. So this will be the outline of the lecture for this afternoon. I have already mentioned also in my previous lecture that in physical abuse, you can easily see the injuries that can happen. No? So looking at this slide now, you can see that there are multiple bruises, no, all over the body, as well as an ulcerating wound on the left hand of this patient. Now, even the areas of the feet and the toes, and the knees and the legs. The definition of physical abuse by WHO is it results from an act of commission which produces an actual physical harm or holds potential for harm which is reasonably within the control of a parent or person in a position of responsibility, power, or trust. Now, it can be a single incident or it can be repeated acts. So there are many forms, no, like slapping, punching, shaking, kicking, burning, shoving, etc. So, as the doctor who's going to examine, you really have to raise the red flags, and you have to ask yourself, if you have a patient with injuries, is it accidental, or is it inflicted or a form of abuse? So remember, if it's an accident, it is an event occurring randomly, unexpectedly, or by chance. It is intentional if there is an event occurring voluntarily, assuming conscious or unconscious control, reflecting underlying conflict or impulse. Now, the doctor who is examining a patient who is a suspected case of physical abuse, you have to correlate the history that you have taken, especially on the medical part and the social part, and look at the presenting injuries. You also have to consider the developmental stage of the child and see if this can correlate with the injuries that you have seen. So, these are the things that you have to consider, asking yourself if this is accidental or intentional. One is the age of the child, the credibility of the story of event, changing story with changing information, changing story in succeeding interviews, and eyewitnesses. So, when we are talking about the age of the child, always remember that non mobile infants would least likely sustain accidental bruises, no? Because you know that they are not yet mobile. So less than 6 months, they cannot yet walk, no? They cannot yet run. So bruises are usually uncommon in this particular age group. Now, another thing that you have to observe closely is the demeanor of the caretakers. Are they very defensive? Are they combative, hostile? Or the opposite, no? They are passive, like there's nothing happened. So it's not congruent with the seriousness of the injury. Then in your psychosocial or your personal social history also, you have to screen if it is a high risk environment. Like, for example, this patient was born prematurely or with any form of disability, or there is developmental delay, and then check on the parents, no? If the mother might be also a victim of violence, or there is a problem in terms of addiction to illicit drugs, and also anger management, no? How do parents handle anger? So look at the injuries if it is consistent, and what else could cause this injury. So what are the red flags that you have to consider? There is a discrepancy between the history given and the injury sustained. The history of how injury was sustained is incompatible with the child's development. Like, for example, a 6-month-old who cannot yet walk and run will present with swollen thigh, no? So we have one patient who came in with a markedly swollen thigh. I think it was the right thigh. And the resident informed me that they were thinking that it was cellulitis. But I asked the resident to take an x-ray of that particular area, and it was seen in the x-ray that there was complete fracture of the femur. So how can a 6-month-old baby who cannot yet, uh, walk and run sustain a complete fracture of the femur? Another will be the story changes or varies. So you really have to listen carefully to the answers, no, of the informants, because they might have different versions of the stories. There was an unreasonable delay in seeking care. Now, this is very common among patients who have burns. Parents will not usually bring them immediately, no, after the incident, because they are afraid that there would be question, no, why would the patient had that burn. So usually they would delay in seeking consultation, and you will see later in the pictures where they could present already with infections. Now, the parent or the caretaker denies that there is an injury, and the parent or the caretaker seems hostile towards the child. So the tendency for them is to blame, no, that's the reason why the child had the injury, no, because the child was, running around, not behaving well. So what are the key points that you always have to consider? Do not confront and do not accuse the parent or guardian, and keep your personal feelings private while maintaining a professional supportive attitude. So, what would be our approach? You would always ask yourself, could this be abuse? Because you also have to consider medical conditions that might present or mimic abuse. And then you have to observe the family interactions, relationship among family members, how the family relates to the patient, and how the family reacts to the health professional. So, in your focus history, you are going to ask who was present at the time of the illness or the injury, who was with the child the last time he or she was well, how and where did the injury occur. So, ask the parents about an explanation how the child sustained that particular injury. Does the explanation for the injury fit the scene and the child's physical findings? And do the child's developmental abilities or capability match the injury? So always remember it will be suspicious when the parents say that the injury was self inflicted by the child or a younger sibling. Now, you also have to ask, when did the injury occur? Or has the child been injured before? Then try to look at the medical history if the child has been brought for routine well child care, or this child is a premature because that puts the patient at risk. Does the child have any physical, emotional, or developmental problems? It's also very important that you have to record the information as the parent or guardian mentioned it to you. So remember, I have mentioned this in my previous lectures that these are potential medical legal cases. So it's really very important that you have to record accurately in the medical chart. So in your physical examination, it should be performed on any child whose medical condition is stable. And you have to remove all or part of the child's clothing, but always be mindful, do not frighten or embarrass the child. So, in your physical examination, you have to check all over the body for deformities, bruises, lacerations, abrasions, punctures, burns, tenderness, and swelling. In the head, you check for redness, swelling, deformities of the ears, bloodshot eyes, bruising or other injuries around the eyes, swelling or redness of the nose, and lacerations or bruises around the mouth. So in the oral cavity, always check for loose or broken teeth or signs of trauma at the back of throat. So this is a photo of a child with an injury. So you can see there the laceration. And the story behind this is that the mother complained, no, blaming the child that the child was very noisy and very talkative. So the mother said that she just put her palm over the mouth of this child, no, but maybe it was so forceful that the child sustained such laceration. So in the head, you have to check the scalp. There might be some areas of baldness, no, because of pulled hair, or there can be lacerations. And then check blood or watery fluid coming from the ears or the nose, and check for bruising on the bony area behind the ear. Not just like this particular slide where you can see their bruises on the pinna, no, of the ear, and this particular infant, no, was slapped on that particular area. So these pictures also will show us that, especially if the child has a fair complexion, then you can have some bruising, you can have some petechiae. So you also have always to look at this, no? Ideally, if you have a camera where you can label the initials of your patient and you can put in the date and the time, then you can take and document pictures. Now let us move on injuries from falls, no? Because this is a very common reason why some infants and children are brought to the hospital because of fall. Now, there was a study by Helfer, and the results showed no serious injuries, no fatalities among 261 cases when the fall was less than 4 feet. In the Nimityong skull study, falls from less than 4 feet, in 76 cases, there was no serious injury. So, what is the conclusion? Child abuse should be suspected when the cause of the serious head injury is blamed on a fall from a height of less than 4 feet. Now, remember in my first lecture, I have mentioned about shaken infant syndrome, which presents as abusive head trauma. So this is the one differentials that you have always to consider. Always suspect if the baby has been shaken, no? And remember that one of the important physical examination findings will be retinal hemorrhages, no? So you have to do your fundoscopic examination. In the Kirschner study, these are suspicious stories of fatal cases, no? Like the child fell from a low height, child fell onto the furniture or the floor object, the child was unexpectedly found dead, or the child choked, shaken to dislodge the object, the child turned blue or cyanotic and then shaken to revive, or a sudden seizure activity. It could be possible the parents will tell you that they did resuscitation efforts caused by injury, traumatic event, a day or so, trip or sleep carrying a child, another sibling did it, or the child left alone for a short time, or the child fell down the stairs. Now let's move on to abdominal injuries. No? So this is another area where the child can really sustain injuries that can cause mortality. In fact, this is the second most common cause of death from physical abuse. The first or the number one cause will be your abusive head trauma. So this can be the different inflicted abdominal injuries. No? It can be a hematoma on the wall of a small bowel, the pancreatic injury, you can have intestinal perforation, ruptured blood vessels, ruptured liver or spleen, or kidney contusion, or laceration. So this can be the different organs that can be affected, no? Injuries to the liver, the small intestine, the pancreas due to a blunt trauma to the upper abdomen, or scrotal hematomas due to direct blows. So this is a picture, no, of an endoscopic exam where you have their bleeding, or you can have their some inflicted abdominal injuries with visceral injuries already. So let's move now to fractures or skeletal injuries. So this is common in children who have been physically abused. 80% of abusive fractures are seen in children less than 18 months. So in 1991, a study found out that 39 young children with humeral and femoral fractures, 23% were inflicted. And a subsequent study of these same investigators of 250 fractures in children showed that younger than 3 years of age demonstrated that 24% were due to abuse. So, abusive skeletal injuries, you have to consider these risk factors. A young child less than 3 years old, if coming from a low income family, the child is developmentally handicapped, the child is premature by history, the child has other injuries, or there is no credible history present. So, when you are taking the history, this can be the scenarios, no, that can be given to you. A child who sustains a fracture most often has a change in demeanor. The child may cry, become irritable and difficult to console, and have limited use of the affected extremity. And the caregivers may note that handling the infant or the child in a particular way cause the child to cry or become irritable. So remember, in developmental milestones, no, if they cannot yet roll, pull to stand, cruise or walk, so they should be the least likely to sustain fractures in general because their motor activity typically would not place them in a situation at risk for fracture. And always remember that in cases like this, you don't have other witnesses, no, who can really tell you what happened. It's usually the victim, the child, and then the alleged abuser or perpetrator. In children less than 3 years old, we usually request for a skeletal survey. And these are the different areas where the shots are taken. Now, this is important because you have to ask the radiologist to look for old healed fractures. So it's possible that there can be old healed fractures in these different areas. Now, when we look at the fractures, there is a category where they would say that this is specific, no, highly specific for physical abuse, like it's a metaphyseal chip fracture, it's a bucket handle fracture or rib fracture, especially if it's posterior in location, scapular fractures or spinous process or the sternum. Moderate if it is a fracture of different ages. It's a multiple or bilateral fracture, epiphyseal separations, and so on. So, these are common fractures in children but have low specificity, like a subperiosteal new bone formation, clavicle fracture, long bone shaft fractures, or linear simple skull fractures. So this is an example of your metaphyseal chip fractures, no? So you can see there the arrow which has been pointed. Then you can also have your bucket handle fractures, no? So in this particular area, you can see it there. Then you can have your posterior rib fractures, no? And also, it's moderate if you have a multiple or bilateral fractures or you have fracture of different stages. So in here, you have a humeral fracture. And moderate also if you have multiple or bilateral fractures, fractures of different ages, epiphyseal separations, vertebral body fractures, or you have digital fractures or complex or multiple fractures. So again, this is an example of a complex or a multiple fracture. Now, these are the imaging recommendations for the skeletal injury. So, if it's 0 to 12 months, imaging can be skeletal survey, follow up skeletal survey after 2 weeks. And then you have 12 months to 2 years, you have skeletal survey or bone scan, 2 to 5 skeletal survey or bone scan, and 5 years old and older. So this would depend now on the site of the suspected area of injury. So there is such thing as the dating of the fractures. So, but this is actually an inexact science. So the radiologic estimates of the bone healing occur as a continuum with considerable overlap. So the radiologic estimates of the time of the injury are made in terms of weeks rather than days, and a proficient radiologist can clearly differentiate recent from old fractures. So they say that periostal reaction can be seen as early as 4 days and is present in at least 50% of cases by 2 weeks after the injury. And the remodeling of the fracture appears 8 weeks after the injury. So this slide now will show you the different dating of the fractures, no? But I don't expect you to memorize this one. But at least you know that after the incident that happened, what would be the expected findings, no, that would be present in the x-ray, no? Like for example, the incident happened 2 weeks 2 weeks already, and the child was brought to you, then you can already have periosteal newborn formation in the x-ray in the area that has been affected. There are medical conditions in pediatrics that might present with fractures, and one of them is osteogenesis imperfecta. So, if you would recall, this is a rare inherited condition that results in bone fragility and propensity for fractures with routine handling or minor trauma. So, the hallmark of this disorder is a genetic mutation resulting in an abnormal synthesis of type 1 collagen. So you have to rule this out, not that your patient doesn't have osteogenesis imperfecta. Another one is your nutritional rickets, which can lead to bony lesions that may be confused with metaphyseal fractures. So this is also one of your differential diagnosis. Now let us move on now to skin findings, now, which is the one that you can usually see or very visible in patients who are physically abused. And of course, no, bruises will be the most common injury, but at the same time, it's a common accidental injury of childhood. So you have to look at in terms of the location. No, that's very important. And you also have to consider how in non-abused children would these bruises would look like. So bruises that are small, sustained over bony prominences such as the knees and the shins. No, so these are very common areas that would be affected, especially if the child would fall, no, or slipped. And then bruises are usually on the front of the body, with those on the head usually on the forehead. But if these are the areas, no, like buttocks, the back, the forearm, the face, the abdomen, the hip, upper arm, posterior leg, or foot, so these are uncommon sites. Now, skin findings that are suggestive of physical abuse, you have to look at the developmental milestones, no? So bruising in children who are not independently mobile, or bruising in babies. Bruises that are seen away from bony prominences, or multiple bruises in clusters and multiple bruises of uniform form. So the bruises can carry the imprint of the implement. So we call that an implement mark, no? Like for example, the child was slapped on the face, so you can expect, no, the fingers or the shape of the hand to be marked on the face. Or you can have loop marks from the cord, or if a fork was used, then you can have a puncture wound. Or around the neck, no, if there was a rope that was put there, you can have your ligature bruises. You can even have bite marks or pinch marks. So, in older children, there is what we call as defensive injuries, no, which might involve the upper arm. Because, like for example, if the perpetrator would try to struck the face, no, obviously older children would try to cover their or protect their face already. Or it can be outside of the thigh or on the trunk and adjacent extremity. Now, this slide would show us the locations of accidental bruises or abusive bruises. No? So, these are the locations that you have to take note. Now, aging of the bruises is really not reliable because there are a lot of variables that you have to consider, like the depth of the bruise, the location, vascularity of the underlying tissue, or the age and the complexion of the child. So it's not really accurate, no? So remember, when you bump into something initially, it could be reddish, no, in color, then it would change to uh, yellowish, or it's red, blue, and then purple. So that's why they said that this is really not reliable. So I'm going to show you some very sensitive pictures, no, of some patients that we have seen. So this was a child who is an orphan and was brought to us because of two black eye or periorbital hematoma. And the story of the aunt who adopted this child is she bumped herself, no, on the door while walking. So you can say that it's a very fantastic story, but you know that the injuries that the child sustained cannot explain, no, by the story that was given by the aunt. So this particular child sustained blows, no, on the face, sustaining the bilateral periorbital hematoma or two black eyes. And then whip looks. So look at the location at the back. So you can have their whip marks or loop marks, no, that was used to hit this particular child. So this is another picture where it is now on the lateral aspect of the thigh. So you can see here the different whip marks, the loop marks, no, that was used to hit this particular child. And then the hand-shaped bruise. So you cannot see in this particular chart very well because the child has a dark complexion, but this one you can see the shape of the fingers, no, of the person who slapped, no, the cheeks or the face of this particular infant. So this is another example of your hand-shaped bruises. Now, if something that is like a fork, no, that has been used, you can have a puncture wound. So this was a child who sustained a puncture wound caused by the fork because the mother was cooking and the mother got angry at the child and then got the fork, no, and then hit the child with that. So the child sustained a punctured wound. So this is an example of a child with rope burns around his arm, no, because I think it was a rope, no, that was tied tightly for this particular child so that he will keep still. And for this patient, you can see here there are rope marks, no, on the neck, and the same patient also have a some conjunctival hemorrhage, no, because of this. Now, bite marks can also be seen. So this is the type of ruler that's recommended so that you can measure very well the lesions that's present. So this is how you differentiate an adult compared to a child bite. Okay? So from canine to canine and then to a second molar. Or it can involve for an adult, one arc, for child it's two arches, and a 2.5 to 3.5 between canines for an adult bite and less than 2.5 centimeters for a child bite. So this was a child who also presented with a bite mark, and the one who beat this particular child is actually the younger brother, no, because they had a fight, and the elder sister sustained it. So we can take photography of the bite marks. So you have to have the ruler and the patient ID in the photograph. You can have multiple views. You can swab for saline using the saline swab if you want to test for the DNA or ABO matching or wax impressions for matching. So this is an example of an infected pinch marks, no, inflicted on the child by the mother. The same on the fingers of this particular child, where you have their infected pinch marks, and also on the toes of this particular child. Now remember, if you see bruises all over the body, no, especially on the back and the buttocks in different areas, and this child actually sustained bruises all over the body, no, even the face of this patient. So this is also another patient who had bilateral periorbital hematoma. And we even have some patients where the bruises, no, are located in the inguinal area already, no, or the upper part of the thigh. So this one, you have seen this already, no, this was slap here on the ear, and this is a linear scar, no, and a sharp knife was used, no, that's why this particular patient sustained the linear scar or an implement mark. So you can see here that this is a U shape and a hand slap and inflicted finger marks. So what are skin manifestations or skin presentations that you have to rule out, no? One is Mongolian spots. So always remember, this is present on the sacrum but can be present on the lower extremities or forehead. It's dark in color, but usually as the child increases in age, this would also disappear. And it is not accompanied by tenderness or edema. Now, another medical condition that you have to rule out will be your immune thrombocytopenic purpura. Remember, this would present with petechiae. And then you have hemophilia A and B, which can have bleeding on the joints, and also your von Willebrand's disease. So other conditions can be vascular inflammation, Henoxian line purpura, which can present with purpuric palpable lesions on the lower extremities and the torso. Now, I also like to share with you that adult women, no, are also victims of physical violence. So we have one patient here, no, who told us that whenever his husband is angry at her, he would get the knife, no, and then put all those marks on the neck and the upper chest, no, sustaining those marks there. This one was strangled, no, by the angry husband also. And this particular patient, no, came into us wearing long sleeve, and then when we interviewed her, she only disclosed that she had hematomas on the arm, no. But during examination, when we asked her to undress completely, so you can see that even the breasts have bruises, no. And she told us that she was so scared and also ashamed to tell that she was also boxed, no, on that particular delicate part of the body. So very common, no, among adult women. And for these cases, no, uh, these patients sustained chemical burns on their face. So the story there is they have husbands who don't know how to manage their anger, and they were both perpetrators were taxi drivers, no? And this one, the angry husband threw a cup of hot water over the face, so she sustained burns. And this one is more worse because the husband threw acid, muriatic acid. No, good thing that she closed her eyes during the incident, so her eyes were not affected. Now let's move on burns. So inflicted burns are a significant cause of morbidity and mortality, and inflicted burns account for 25% of all hospital admissions for children. So it can be a pattern burn depending on the object that was used, no, like a cigarette, curling iron, or a flat iron. Or it can be a scald burn where we have a glove or a stocking appearance. There can be burns to the buttocks or genitalia. It can be extensive second or third degree burns to the hands or feet or splash burn. So these are the different mechanisms. It can be thermal, electrical, chemical, or radiation. And just as review in surgery, no, remember you have to classify the degree. It can be partial thickness, it can be deep partial thickness, or it can be full thickness, which is third degree, and deep into the muscle and bone, which is the fourth degree. So in the history, you always have to ask, no, what really happened, because you have to have a clear history of contact with a hot object or liquid. And so there would be a lot of stories, no, or versions that the informant can give you, like children grabbing uh, a cup of hot water or coffee, or toddlers which can reach up to pull containers of hot liquid from the table, the stove, or the microwave, and older children who have dexterity to play with and ignite matches or lighters. So you really have to take detailed, no, information about what happened. So you have now to differentiate again accidental versus abusive, no? So for accidental from hot liquids, usually it's the anterior, no, plane of the body, and they have a concentric radiation of the depth of the burn. Or if it's caused by hot food, it can be more viscous and adherent. And then you also have to consider, no, the clothing that was used, because sometimes the clothing does not protect against the degree of the burn injury. So these are pictures now of patients. So you can see here a patient which have blisters, no? And this was caused by a hair dryer. So this was considered a dry contact burn. This is from a cigarette, and then this is a pattern burn. And this one was brought to the hospital, I think, a week after the incident, no? So accidentally, the father claimed, no, that there was a hot liquid that was that caused it, no. But when we asked the patient, especially this girl, uh, they said that a hot flame, no, was oil. I think it was an oil flame, which was caused that was thrown to them. A hot lamp, no, that was thrown and which caused these burns. So this particular patient was asked to sit on a tub of hot water. So you can also have forced immersion scalp burns like the stocking glove. It's usually bilateral, And then there are spared areas which we call the donut burns, no? Because these are the areas which come in contact with the lower part of the basin. So this is an example of your stocking appearance. So it's bilateral. And you can see here the perfect line of demarcation for this particular. Now, we also have some children who might present with unusual patterns like this particular patient, no? Who we initially thought really had burns, no, all over the face, but we asked the derma section to check on this particular patient, and these were the two conditions, no, that they have considered. They have bullous impetigo or epidermolysis bullosa. So remember, your bullous impetigo is caused by Staph aureus or Streptococcus pyogenes. So there would usually a bullae formation. So they can be mistaken for partial thickness burn due to cigarettes, and there would be yellow crusting, no, on the top of a ruptured impetigus lesion. The other, which is your epidermolysis bullosa, is a rare inherited condition in which a large bullae can form either spontaneously or over areas of friction. So that patient had epidermolysis bullosa. Now, recording or documentation is very important, no, in cases of abuse. So you have to have your written report, but always remember that you have to record it verbatim. Like, for example, in this example, the parents stupidly explained that the baby crawled out of the window. Now, that was the version of the historian, but you have to quote and say his child crawled out of the window by himself. So you have to record who was present, what happened, when and where injury occurred, how it came about, and do not attempt to explain why. So this is an example. Our case is a 13-month-old Joey who was with the mother's partner in the living room of their house. The mother stated that pag-uwi ko ng alauna ng hapon, umiiyak si Joey. Namabaga yung hita niya. The mother's partner said, naglakad siya, hawak yung silya. Paglingon ko, umiiyak siya. Nadapa siguro, pagkita ko, ayaw na niyang galawin yung paa niya. So you have to record, describe, no? The color, the size, the location, and the shape. And in fact, you need to draw, indicate location and measurement. So you really have to have objective documentation of the physical findings. Like, for example, for this patient, Joey's right thigh, swelling with purple and red bruising over the right middle thigh, swelling from 5 cm above the knee toward the hip measuring 10 centimeters. Joey did not move the hip or knee during the PE. Tenderness with crying noted upon touching the right thigh. So this is how you're going to write it in the chart, no, with a definition or description rather of what have you seen, and then your documentation like the x-ray. So Joey's right thigh had a spiral distal fracture of the right femur. So in your impression, you can now write a 13-month-old male with fracture of a distal right femur. The circumstances provided by informant with the physical examination are highly suspicious for physical injury or inflicted injury. Now, in cases of physical abuse, it will be very important to give the healing time. No, for this patient, it was more than 30 days. Why? Because when this case goes to court, now depending on the healing time, the longer it is, of course, the higher the punishment. So other area that you have to consider will be communication with parents and other care providers. So always remember, you have to be supportive and non-judgmental. Do not make accusations. And then, again, I'd like you to remember you have to separate the interview, separate the parents or the caregivers, and you might ask yourself, no, why does it happen? So there is what we call that there is dynamics of abuse, no? Always consider abuse increases in times of economic stress. The habits of abuse are often learned in childhood and later passed on in the next generation. So that is why we always try our best to educate parents, no, that hitting the child is not the best way to discipline the child. Family members who engage in other acts of domestic violence, such as spouse abuse, are more likely to perform violent acts against children. Drug and alcohol use by parents lowers their ability to control frustration, increasing the likelihood of abusing their children. And physical punishment is a spiraling problem for some parents who will use progressively greater force to control their children. And all children do aggravating things to test the parental boundaries. So I know not all of you will go into pediatrics, but I'm sure that most of you will become parents in the future. And I hope that you would always remember, no, my lecture, that you need to control your anger, and there are other avenues to discipline the child. No, do not hit the child. So remember also always that there is a multidisciplinary response when we are taking care of children who are abused, and we always do it for the best interests of the child. So this is one of the cases, no, that we had before. The child came in with multiple bruises, with periorbital hematoma. No, the child, she was so quiet, aloof, no, and not interacting with the staff. And then after several sessions of treatment and talking with the child, so she improved, no, and she becomes more playful. She was interacting already. Now, the reason why I appeal to you not to close your eyes or do not deny, no, if you are really suspecting that you have a patient who is abused, especially physically abused, is because we don't want your patient not to become a case of fatal child abuse. Thank you for your kind attention.